Hi, it's Bree Smith, SN, here to help you succeed in nursing school and on the NCLEX.
In this video, we are covering pain and inflammation pharmacology. We are covering a wide variety of drugs, so check the chapters and timestamps to help you find specific ones you are wanting to focus on. Let's begin. This video will begin with covering analgesics that are not opioids. We will start with first-generation non-steroidal anti-inflammatory drugs, also known as NSAIDs. Examples here include acetylsalicylic acid, more commonly known as aspirin, ibuprofen, and ketorolac. These medications confer analgesic, antipyretic, and antiplatelet effects in the case of aspirin, for the patient by interfering with prostaglandin synthesis. Side effects include GI distress, and so NSAIDs should be taken with food. Overuse and chronic use may increase the risk for gastric bleeding and ulceration, and so the patient may be indicated for prophylactic administration of a proton pump inhibitor, such as misoprostol, to reduce these complications. Patient teaching should emphasize reporting black or tarry stools, which may indicate a GI bleed. These drugs impact the kidneys. An overdose, as well as chronic use, can lead to nephrotoxicity. Ototoxicity is also a concern with these medications, manifesting potentially as tinnitus and dizziness. Salicylism is the clinical term for aspirin overdose, which presents commonly as hyperventilation leading to respiratory alkalosis. Anticipate to treat with activated charcoal, sodium bicarbonate, or gastric lavage. A couple NCLEX nuggets here. Never give aspirin to children, as it is linked with risk for Ray's syndrome, which results in severe inflammation. The only exception to this is if the child is diagnosed with Kawasaki disease. To remember this, note that the abbreviation for aspirin, ASA, is found within Kawasaki. Risk for thromboembolic events increases with these drugs, with aspirin as a noted exception amongst the other NSAIDs. The antiplatelet effects of aspirin makes it useful in the prevention of thromboemboli, and as such, it may be prescribed to patients with atrial dysrhythmias, TIAs, and MIs. These antiplatelet effects also pose a risk for increased bleeding for patients on concurrent blood thinner medications or for patients at increased risk for bleeding postoperatively. Let's now focus on a non-NSAID, that being acetaminophen, or more commonly known as Tylenol. This medication confers analgesia and antipyresis, but only acts to reduce inflammation in the CNS rather than systemically, as is the case with our NSAIDs. Tylenol, ending in L, is potentially toxic for our liver, so just keep those L's in mind. Overuse or overdose can lead to hepatotoxicity. To reduce the risk, there is a maximum daily dose of 3 grams for most patients, which should not be exceeded. For patients with asthma, minor pain relief may indicate the use of acetaminophen rather than NSAIDs. NSAIDs can lead to bronchospasm, leading to exacerbation of asthmatic symptoms. To help you remember that acetaminophen is okay for asthmatic patients, we can thank my classmate Abby. Think of a wheezy kid with asthma taking a seat with acetaminophen. Acetaminophen is the preferred OTC pain management medication for pregnant patients as well, whereas NSAIDs can lead to structural abnormalities for the developing fetus, such as premature closure of the patent ductus arteriosus. NCLEX nugget here. Acetylcysteine is the antidote for acetaminophen toxicity, given to prevent further hepatic damage. To wrap up this portion, our last drug to focus on is the centrally acting non-opioid analgesic tramadol. It is indicated for more moderate to severe pain that might not be covered by our NSAIDs or Tylenol. Despite not being an opioid, there is still CNS depression to watch out for. Priorities for the nurse when this drug is administered is to monitor respirations and level of consciousness. Now we will cover our opioid analgesics, beginning with our prototypical opioids such as morphine, fentanyl, hydrocodone, oxycodone, and meperidine. Opioids promote analgesia in the body by acting upon receptors in the central nervous system, which block pain reception. Our goal when administering these medications is pain reduction. When possible, utilize patient self-reported levels of pain to determine the effectiveness of the administered dose. Reevaluate these levels about 15 minutes after IV administration and anywhere from 30 to 60 minutes if given PO. When administering a bolus dose IV, make sure to check reference guides for the appropriate time to administer the drug over. Opioids generally require a slow and controlled IV push, as to not overwhelm the patient. Especially when given to chronically ill, hospice, and terminal patients, there is no upper limit for dosing for morphine. Titrate to effect and do not withhold pain medication from these patients unless their safety is at immediate risk. I'll point out that the CNS depressing medications can lead to side effects where everything becomes low and slow. Expected side effects such as flushing and pruritus are expected to diminish with continued use. However, constipation will not alleviate on its own. Patients should be encouraged to increase fiber, fluids, activity, and take a stool softener if indicated. Like all CNS depressant medications, the patient should not combine these drugs with other depressants, such as alcohol. A quick NCLEX nugget here. Meperidine, brand name Demerol, is contraindicated for use with older adult patients, as well as patients taking MAO inhibitor medications. Administering meperidine to elderly clients may put them at increased risk for seizures. Priority assessments for these drugs relate to respiratory function, level of consciousness, and pain levels. Monitor the patient closely for indications of respiratory depression and severely decreased level of consciousness, and promptly administer the antidote, naloxone, if overdose is suspected. This leads us into our prototypes for our opioid antagonists, utilized in reversing the effects of narcotic overdoses. Our prototypes are naloxone or naltrexone. They can be administered in a variety of forms, most commonly intranasally or intravenously if IV access is available. Abstinence syndrome may be a consequence of administration, where the patient exhibits severely uncomfortable and distressing withdrawal symptoms due to the reversal of the sedative effects provided by opioids. Monitor the patient for hypertension, vomiting, cramping, and expressions of pain. Provide for comfort and patient safety throughout the withdrawal process. We'll now touch on opioid agonist-antagonists, which have a milder analgesic effect, yet less adverse effects due to the concurrent activation and inhibition of the CNS opioid receptors. Our prototypes are butorphanol and buprenorphine. These drugs do cause some systemic depression, including bradycardia. If given to patients with existing or history of cardiac insufficiency or myocardial infarction, angina or infarct may result if cardiac workload exceeds capabilities of the patient's function. For the last portion of this review session, we'll touch on a couple prototypes for inflammation-reducing medications. Allopurinol is indicated for the treatment of the inflammatory condition gout, working to block the formation of excess uric acid crystals and promote excretion through diuresis. With that, important patient teaching includes that the patient should increase fluid intake to at least 3 liters daily to flush out these metabolic wastes. To make treatment more effective, the patient should also be instructed to avoid food and drink high in purines, as well as alcohol and caffeine. The patient should also be sure to receive regular eye exams, as buildup of gouty deposits can increase risk of visual disturbances such as cataracts. Let's now talk about a majorly emphasized class of medications, those being our glucocorticoids such as prednisone. Steroidal medications reduce inflammation by suppressing the immune response. While inflammation is reduced and patient comfort is increased, there are many potential complications of steroid use that we should be aware of. Glucocorticoids, especially if used long-term, may lead to hyperglycemia, hypokalemia, and other electrolyte imbalances, as well as increased risk for osteoporosis and fracture. One of the greatest risks to patient safety relates to increased risk for severe infections due to the immune suppression conferred by these drugs. The patient should report indications of infection, such as sore throat, fatigue, or even minor temperature elevation to the provider. Patients should also be instructed to engage in proper hand hygiene, avoid crowds and sick individuals, and avoid live vaccines. If used for short term, the patient should discontinue the dose with gradual tapering according to provider instructions. For those on a longer course, alternate day dosing prior to discontinuation may be indicated. Abrupt discontinuation can lead to manifestations of severe adrenal insufficiency, such as severe fatigue, loss of appetite, abdominal pain, and skin discoloration. Thank you for watching this quick review of analgesic and anti-inflammatory drugs. While this is far from a comprehensive breakdown, the most commonly emphasized points on the NCLEX and in clinical practice are covered here. Please make sure to utilize your assigned textbooks and modules in addition to this review.
Remember to keep studying and keep working hard.